Thank you. So my name is Adrien Picod. I'm an anesthesiologist and intensivist in Paris and currently a PhD student in Alexandre Mebaza's lab. So I guess I'll be the outlier of the day because my talk is actually about refractory septic shock and the prognostic impact of norepinephrine equivalent dose and biomarkers of hypoperfusion. So in critically patients admitted for shock, a significant proportion of deaths are due directly to refractory hypotension or refractory hypoperfusion. And in addition, the lack of response to maximal vasopressor support is a frequent motivation of end-of-life decision, but I'm sure that there could be many definitions of what could be maximal vasopressor support. And this is because the clinically applicable definition of refractory shock is difficult to implement. Theoretically, it could be the inability to maintain an adequate tissue perfusion despite some amount of vasopressor inotropes. But the questions are, what are this some amount of vasopressor inotrope and how to assess tissue perfusion adequacy? And this is probably why most studies dealing with refractory shock have investigated the prognostic impact of of the dose of vasopressor and have mostly focused on very high dose with the aim of demonstrating futility. But actually, there is a large variability in the outcome associated with a very high dose of norepinephrine, ranging from 60 to almost 100% death. And in addition, it could be interesting to focus on biomarkers of hypoperfusion to have reproducible and quantitative assessments. And of course, lactate reflects hypoperfusion, but also stress and drug-induced glycolysis or mitochondrial dysfunction. And conversely, circulating DPP3 is a new biomarker which has been associated with mortality and increased organ failure in critically patients with shock. And our current understanding of its pathophysiology is that it is released from dying cell. Thus, it could be a candidate biomarker of hypoperfusion. So to explore this question, we used the Adrenos-1 cohort, which was an observational cohort of sepsis and septic shock patients. There were almost 600 patients with a mean SOFA of 7, and the overall day 28 mortality was 22%. Our primary objective was to explore the relationship between the norepinephrine equivalent dose and day 28 mortality, and to define a cutoff with a prognostic implication, and also to assess the incremental value of lactate or circulating DPP3 on top of the dose of norepinephrine. And importantly, in this cohort, the norepinephrine equivalent dose is the sum of all catecholamine vasopressor used because there was very few patients with other type of vasopressors. So we first assessed the relationship between the dose of the maximal dose of norepinephrine achieved on day 1 and the risk of death at day 28. And we found that over a certain cutoff of norepinephrine, there was a clear and positive relationship, almost linear, between the dose and the risk of death. But below that cutoff, the relationship was more uncertain. And that cutoff was 0.2 microgram per kilogram per minute norepinephrine, and we used that cutoff for further analysis. And the Kaplan-Meier curves on the right demonstrate the rather good prognosis of patients achieving a low dose of norepinephrine and the already severely altered prognosis of patients achieving a dose over 0.2. So we next assessed this relationship in the following day, and although the exact shape of the curve slightly differs, there was always the same type of positive relationship. And also the hazard ratio for mortality tended to increase over time, demonstrating that any additional day over such a low cutoff is associated with worse prognosis. And finally, we assessed the added value of biomarkers. And interestingly, both lactate and DPP3 had the same overall behavior with three prognosis groups. First, patients with a low dose of norepinephrine and a low level of biomarker, lactate below 2 millimolar or circulating DPP3 below 40 nanogram per milliliter. And obviously, patients with both a high dose and a high level of biomarker have the worst prognosis. And interestingly, patients with either a high dose of norepinephrine or a high level of biomarker seems to have the same intermediate prognosis. So in conclusion, over such a low cutoff of 0.2 microgram per kilogram per minute of norepinephrine equivalent, there is a clear linear relationship between mortality for each increment, and we could use that low cutoff as a trigger for the clinician at the bedside to identify at-risk patients, maybe do more investigation aiming at deciphering the mechanism at play, and think about an alternative strategy, let's say another addition of another vasopressor with another mechanism of action, such as vasopressin or angiotensin II. And we could use such criteria for enrichment strategy in clinical trials, testing new hemodynamic strategies. And in addition, lactate of DPP3 could be used to further refine the prognosis. And interestingly for DPP3, because it is an enzyme cleaving angiotensin II, it could help define some subpopulations that are more actionable. Let's say, to help prescribe angiotensin II, to help define the population of patients that most benefit of angiotensin II, or maybe in the next future to directly target DPP3 with an antibody inhibiting its activity. So this is a work in progress, and we are now validating this finding in other cohorts. Thank you.
Great job summarizing a very complex topic in only a few slides. Nice job. Questions from the audience? You talk about enrichment in clinical trials. I think it's a great suggestion. These patients are really, really ill, obviously. What would be and you also talk about alternative strategies. So as sort of a trigger of like, you can't just keep ratcheting up the norepinephrine, you have to do something else. What would that something else be if we were to think about even a clinical trial? Would it be another drug? Would it be a mechanical intervention? Like, what are your thoughts?
I think at first it could be used to better define the population who will benefit from another type of vasopressor. There is a lot of debates in the literature in these days about the trigger to initiate vasopressin infusion or angiotensin II infusion, and I think it could be tested sooner in patients with a low dose, already high, but low compared to the existing literature.
Right. Great suggestion. Other thoughts or questions? Great, thank you very much.